send it to Wadsworth Laboratory, and they have you could run an encephalitis panel.
Okay.
It may not be Powassan, it may be a whole litany of things.
Yeah.
And, so yeah, just send it to Wadsworth, to Dr. Wong. And she has a research assay, which is only done there, and she gets determined Powassan virus, and even down to ear tick virus versus Powassan virus. She has that kind of nuance.
So do we have to get a special kit from the health department?
No, it's just you go on the website to Wadsworth and you just submit the specimen yourself.
How do we get it there?
That's the only place doing the testing, and it's free.
Yeah. How do we get it there?
You would ship it. So, and they have shipping instructions.
Okay.
But if you're having an issue, we will help you. So
all right. As long as you can get it. Okay.
So yeah, we will help you. Yeah. So if you suspect it, I mean, it shouldn't be a common thing, but
no. I was going to ask you because and that's how I told the family. I said it's really rare. I mean, but this was a kid that just had. I mean, he's an active teenager, just had this headache, you know, with no meningeal signs, really. Just a brutal headache for days and days and days, constant. And, you know, there was no other clinical signs, and
Because also ruling out the mosquito-borne encephalitis would be a good idea as well, and that's what you do when you do the whole panel.
Okay. Okay.
Yeah, so I'll leave my, I don't have a card, but I'll
put the number on the
put the number, just call the number. If you need help, we can guide you. But Wadsworth has a really good website as well for submitting specimens. And you can do that for a lot of other testing that you may not be able to do at a commercial lab if you want to have it done through Wadsworth.
Okay, good.
No, this is really good. So what I was thinking as I was reading it is like, I think we're ready to consider maybe putting together something published on this. Because I think this, no, but not published to the website, published to a journal.
Oh, really?
Because this is unique information.
It's buried on our website.
Well, it's not even that. It's like, there's nothing like it. Good. All right. So. It may have been dollars, but like this is really good. You're like an outfit, like there's nothing to find.
No one comes to you, hey, we need this, we need that.
Well, it's a good feather. You're going to whatever. So I think that I want to collaborate.
Documentation specialist.
As I'm reading it, I think it's worthwhile.
You know, that may be
the way you did it.
The truth that we have
Working that as well. I like how the
anti-TB
has nothing to support.
We already spend way too much time. You're not doing medicine to satisfy some kind of digital world. And I mean, I can put up with a lot, but I just
It's frustrating over a lot.
there was a point where you could do it, but now that part is now grabbing so much more of your time, and it's distracting. You got to do something so that
and I think it's shorter. You know, it's on the map. Yeah, it's on the map. But it'd be great. We were practicing up on the drag. Like I said, I love it. It's your typical. Just try to show up. Yeah, I don't want it.
It's already almost.
You can't be a matter. Can't get it to that. If you're in Dragon, instead of dictating, so let's have you a thing. And if you're dictating, get to this part and this part, Dragon, just like everything else. I can do it. If I go to here, then dictate what's in there. Import that. It's great. Import it. But you got to go import, tag, do the job, put it in there, it takes way too much time. Yeah. And so it's not a
But first they would give you the most.
They look nice.
Variety, but.
And if you spend the time to do it, you are actually creating a piece of artwork. You are not. Yeah, there you go.
Well, I know they're trying to get everything, and then sometimes things would get so that you could import stuff and not have to dictate the whole thing.
As I was reading it over, and that's what going, I go up to the list, I read down to everything is chronological, you know, like, only because I'm, now it's,
I was sitting over there, like,
you know,
maybe I'll have to look after all.
so and then the next window, jump in, import it, then start, you know.
Oh, I don't know, because
It's just, so it's so exciting. I've been with Dragon for 10 years.
Oh, okay. This is when I came here.
Yeah.
Oh, okay.
So I don't want to, I don't mind the numbers that they out for doing the and I'm doing one on Thursday night. It's like a deep
It's just a blessing for us to try to read stuff that there's a lot of
everybody has a template. And you don't need that one.
You're going to be reporting today or not? Yeah. So there's going to be like any discussion. What's been added? It's almost better.
I don't know these that's why I you see that's the other thing that you can then have to do it. You got to go back and read it and edit it. That's the part of the time that
has to be fun. Which one did they leave that 44 hours? Do we actually start
you have to just write it. You can't correct that. No, it's all good. So yeah, so that's what's my thought. I don't know. It's funny. Probably because of the future. I just think it's more something it's not so much science because there's not so much writing anymore. English language is going by the wayside of schools because they're doing that. And you know, things like that's always a good thing. It's okay, you know, if you're a mathematician or a researcher, you better be the right.
But you know what?
Let's just introduce myself. Okay.
Like, burden down with things that
Now I feel free. I like to. All right. Good morning, everyone. How are you doing? All right. My name is Andrew Rotans. I'm from the Dutchess County Department of Health. I'm the Senior Public Health Advisor, and I've been at the Department of Health for about 26-ish kind of years, going on 27. I work in the Communicable Disease Control Department, and I'm in charge of zoonotic and diseases and HIV, STD, two completely different subject areas, but I really love both for different reasons. The zoonotic disease program, which I'm the only person now. We're looking for in the process of hiring someone else, which I desperately need. So what zoonotic diseases are diseases that have an animal vector in the middle of it, and usually we get the disease from exposure from an animal. And you don't think of a tick as an animal, but it is an animal. And that's why it's in the zoonotic disease realm. But more specifically, when we talk about ticks and mosquitoes, we generally use the term arthropod-borne diseases to describe it, and that's probably what you know more. But zoonotic disease is broad. Rabies is in there, things like leishmaniasis, some uncommon plague. So you don't think of it. And sometimes with the zoonotic diseases, when a person gets them, they can transmit it person to person, like Ebola, for example, or like in the case of some of the tick-borne diseases, when they donate blood, it can be transmitted that way. So but the animal cycle in nature is mainly how we get the disease. So today I'm here to talk to you about a survey that we've been conducting this survey for a number of years, and I have Katie Wheeler-Martin, the epidemiologist for the health department here, and she's going to jump in because she helped write this presentation, so, and she knows a lot of the nuance of things that I may not know. So if I forgot something, or if there's a question I can't answer, she may jump in. So she's in the audience here. She did a great job, and actually I was talking to her that I think that this is something very unique, surveying providers about what they know, how they feel, what you feel about, and what you practice regarding tick-borne disease. And we've been doing this for a number of years just to help us understand how we can better serve you regarding this very important topic in Dutchess County. Then before I go any further, too, I want to thank all of you as well for your help in getting this survey done. We would like a larger sample size. As you'll see, it's only about 10%, but of the providers in Dutchess County. But I know you guys are really busy, and to do a survey is very difficult. There may be another way, as we go in the future of doing this, one of the best ways, I think, is not to survey monkey or sending it to paper, is actually traveling to you and having you do it for us, almost like the clipboard guy at the mall kind of thing, because I think that probably, but sometimes, because you guys are so busy, just like the idea to sit down and take 10, 15 minutes to do this, it's very difficult. If I showed up, you might just say, oh, we can have a cup of coffee and do the survey together, and we may increase our sample size next time. So, and may be able to reach out to providers that may not be as comfortable doing this survey, though, because there's a wide range of attitudes regarding how to apply to our tick-borne disease. Okay. We're not moving. Sorry. Hello.
Hi. Slideshow. Right.
Oh, I see. That's what. Thank you. Sorry. Oh, me. All right. There we go. Okay. All right. About the survey. The goal is to assess the current knowledge, attitudes, and practices in the recognition and treatment of tick-borne diseases in Dutchess County. And it was distributed to all medical practices in Dutchess County by fax or email in May of 2014. Eligible respondents included physicians, nurse practitioners, and PAs practicing in Dutchess County. The final sample is 111. 61% were MDs, which is very good, okay. 19% were NPs, also very good. 16% PAs, and 4% DOs. Response rate was 10%, about 10% of Dutchess County practitioners. And was that the best rate we ever had, would you say?
It's actually one of the better ones.
Yeah, so we pushed.
For surveys in general, it's not unexpected.
Yeah, so, all right, okay. The grouping of specialties for analysis, there was 39 children's primary care, there were 29 in adult primary care, there were 21 in relevant specialties, and 22 in other specialties. We grouped providers by their specialties for analysis, and the largest group being pediatric and family medicine practitioners. Adult primary care was the second largest group. We'd expect both pediatric and adult primary care providers to most frequently encounter tick-borne diseases in their patients. We called the third group relevant specialties since we would expect providers in these specialties to at least occasionally see patients for reasons of tick-borne disease. The fourth group of other specialties include those we would expect to least frequently encounter tick-borne disease in patient populations. But they should be included because they may encounter it, I've worked with STDs, and I find that, people show up to another specialty maybe with a symptom and weren't thinking STD, for example, like a rash or something like that. Okay. Thing is, there we go, that's better. Across the board, regardless, especially about 2/3 of providers surveyed feel that tick-borne diseases are a serious health concern at Dutchess. Most other providers feel that tick-borne diseases are at least a moderate health concern. This has really not changed much over time. It's you guys feel it's a problem. The population of Dutchess County feels it's a problem. We do a community survey, and Lyme disease is always considered, it's always #1 health problem issue in Dutchess County. So. But I would just tell you, over the years, we've been dealing with this since about the late 80s, early 90s, the issue of Lyme disease and tick-borne disease in this county. And I will say that there's a high knowledge of the community as well of this. We've sort of learned to live with it here, as you know, as opposed to some of the new areas. I'm doing a talk later with maps, epi-maps, and it's moved up north and moving over west of the state. And those are the new areas where, like, you know, all the education and stuff that you guys have, they're just starting to do there, the community and the providers. Ever tested or treated patients for tick-borne diseases? Nearly all primary care providers and relevant specialties surveyed had tested or treated patients for Lyme disease, as well as about half of all other specialties. The vast majority of primary care providers have also tested and treated patients for Babesiosis, Anaplasmosis, and Ehrlichiosis, compared with less than half of other specialists of any type. Fewer than 50% of any providers have tested or treated for Rocky Mountain Spotted Fever, which is not as prevalent in Dutchess or New York State compared to other regions. Less than 1/4 of providers have tested or treated for Powassan virus, which is extremely rare but recently found in the Hudson Valley. And that's an awareness issue. We were, I don't know, your name?
Tom Robinson.
Dr. Robinson. We were talking, oh, you're my mom's doctor. Anyway. It's a small community here. So, yeah, so, now I lost my train of thought, but anyway, we were talking about some child you saw with encephalitis, but like it's just Powassan is a new thing, and it probably always was here. It's just that we never tested for it before. What changed was in 1999, West Nile virus, and people started thinking about encephalitis, arthropod-borne encephalitis, and Powassan was sort of like discovered as an offshoot of that. As more and more samples were going to the state lab for West Nile, they ran a whole panel, and Powassan was on the panel. And we're finding some of these people that thought West Nile had Powassan virus. And they are starting to do surveys of the ticks in the area, and there's a very small percentage of ticks that they find with Powassan virus, or what we call deer tick virus, because it is in the, this is a little aside from the talk, but like the virus is in 2 species of ticks. The Powassan virus is in the woodchuck tick, which is rarely attaches to humans. The deer tick virus, which is a subset of the Powassan virus, is in the deer tick. Okay, self-reported good or very good knowledge of tick-borne diseases. We asked respondents to self-rate their knowledge of each tick-borne disease. This chart shows the proportion who rated their knowledge as good or very good. The patterns follow experience and treatment shown on the previous slide, with most primary care providers rating their knowledge of Lyme disease as good or very good, compared with 60% of specialists. Less than 70% of providers and fewer than 20% of specialists felt they had a good knowledge of Babesiosis, Anaplasmosis, and Ehrlichiosis. On average, less than 20% of providers felt their knowledge of Rocky Mountain Spotted Fever or Powassan was good or very good, regardless of specialty. We also asked about emerging tick-borne diseases such as Borrelia miyamotoi, although certainly would not expect a substantial familiarity in practices given their rarity and limited science. Yeah, Borrelia miyamotoi is an emergent pathogen. One of the things that these surveys have told us is that you guys, one of our jobs is to inform you of these new pathogens, and not just do it once, but do it repeatedly so you start to get a better understanding. Because we're just beginning to understand that. Like Borrelia miyamotoi, it's more like a relapsing fever kind of illness, but caused by something they're closely related to Borrelia burgdorferi or Lyme disease. Treated the same way, but and the testing is just starting to be developed for it and that kind of thing. So, and we don't know if there's chronicity or anything like that, which they're not sure with even Lyme disease. And even Anaplasmosis or Ehrlichiosis, the knowledge base with that is because, just think about it, in the beginning, they call all of it Ehrlichiosis, then suddenly they change the name and split it into two different things. So, it's very confusing for you, just as it's confusing for us. It finally found out what the name of it is in the phylogenetic tree, and even with that, they're discovering new ones. They discovered one called Ehrlichia murus-like, and it's out in Wisconsin, Minnesota, and that one is very similar to the Ehrlichia chaffiensis that we commonly causes ehrlichiosis. We don't know if we have that organism here in the Northeast, but they know that it's in the Midwest. It probably is here, but we don't know. So. Reasons for testing patients for tick-borne diseases. Among providers who had ever tested patients for tick-borne diseases, the most common reason for testing was, not surprisingly, symptoms and or abnormal lab findings of tick-borne diseases. Very good. I'm very happy about that. I will tell you when I think further on, it says that 64% of respondents had retested patients with a history of Lyme disease and recurrent symptoms. 55% had tested patients upon request, and about half test patients on the basis of a tick bite. Cardiac complications of Lyme disease are an area of research that are receiving renewed attention due to the recent fatalities in our region. 38% of providers have tested patients with sudden cardiac arrhythmias for tick-borne disease. The least commonly cited reasons for testing patients are to confirm treatment efficacy and as a general screen during your routine patient checkups. And we're glad to see the routine screening one going down, because we used to receive on a year, when we got all the lab reports, about 11,000 positive tests for Lyme disease that we would have to go through and figure out if they're a case or not. That's a lot of testing. And we were finding in some of the early surveys that routine testing as part of a yearly physical was something providers were doing just to test them for Lyme disease because of the prevalence in the area without an actual reason to test for it. So,
yeah, just one quick thing though. I think we saw a slight increase. It used to be more like 3 to 5%, but it's still, on the more uncommon side.
Thank you. Yeah.
Sorry to interrupt, but I mean, I've told, kind of tongue-in-cheek, told people that what you just said is kind of like what I would really like to do is test everybody in Dutchess County to see how many people are positive but have never had symptoms of Lyme disease, no tick bites, no nothing. And, you kind of just said that. You had to sift through 11,000 tests that were positive.
Yeah, but the positive, again, as you know, the testing is not great, and there's a lot of other things that may trigger. A lot of these were very low positives that may have been, because as you know, laboratories set the value, the positive value, and it's different for different labs, and there are a lot of autoimmune things that people have that may trigger. With arthropod-borne disease testing, that's the problem when you get into the screening tests for these, especially with low positives for these. There's a lot of things that trigger very low positive that aren't arthropod-borne disease. And again, for you guys, the surveillance case definition does not apply to you. We have a very specific parameters to prove whether it's a case or not. We have to make sure it's a case. Not to say that those 11,000 that the ones we tossed away weren't Lyme disease. They just didn't meet a very specific criteria. They've expanded the surveillance case definition to include things like headache and stuff like that with the positive testing, but back when I was doing it, I get to have others do it now, it was very stringent, an EM rash, recurrent joint effusion arthritis, very specific things that are unique to Lyme and not to other things. So yeah, so that's what's part of it. It's like it overburdens the system, and a lot of the testing may not be necessary. We could, I think what you're asking for, if somebody wanted to do a prevalence of, because one thing I've never read about, this is just off the cuff, is are the people that get exposed to Borrelia and never get sick, you know, and that's sort of what we're alluding to here.
Right, and that's kind of the tool that I want, because, you know, when you explain that there's a lot of false positive strains, and then you have to verify that, but if you said, you know, 50% of people in Dutchess County are going to come up positive, but they've never had, you know, that's a little bit more ammunition to sort of, you know, squelch the concern that people have about it, you know, because they come in with non-specific symptoms, and everybody, at this time of year, they start thinking about Lyme disease, you know, primarily, and I just said, you know, when you try to flesh out that history, there's nothing that says you're at risk for an arthropod-borne disease. And just some data like that could say, well, you know, here's what it is in Dutchess County, an endemic area, and we're testing these many people positive, and they've never had it. So,
you know, sometimes they do sentinels not just on people, but one of the places they could do sentinels is on dogs, for example. That might give us an idea for exposure, or how many people, you know, sometimes they apply that to people. But, so I think in the beginning of this, Dr. Falco did something sentinel studies with dogs with Lyme disease. So, but no, it's a very interesting point, something to bring from this. Is like, because, yeah, they did that for West Nile, like, as well. They know that, like, a lot of us are exposed to West Nile, but we don't get sick. I don't think people have ever looked at whether we're exposed, a lot of us are exposed to this and don't get sick, or maybe get mild illness that just goes away. So. Lab testing Lyme disease. When asked the survey group specifically, they had to use or diagnose, treat different tick-borne diseases. For Lyme disease, it's just click, okay? Very cute. Over 80% used recommended EI or IFA, which should be followed by Western blot to confirm positive or equivocal results. There is a C6 peptide testing out as well. I don't know if that's commonly used. The C6 is a specific antigen site on the Borrelia. It's supposedly a better.
That's a newer one?
That's a newer one. Yeah, it's not caught on locally, but that one they say is a little more specific to proving it's Borrelia burgdorferi. And click. And then for CBC, general supplemental evidence, over 40% a complete blood count, which can provide supplemental evidence of infection, but it's not sufficient alone for diagnosis. PCR, 40% have used PCR testing, which is not recommended due to low sensitivity to detect Borrelia spiragrates in the brief blood-borne phase of the disease. In the case of Lyme meningitis, CSF analysis can provide supplemental evidence of infection, as has been used by about 20% of respondents. And for EKG, just under 20% have utilized EKG to assess potential cardiac complications of Lyme disease. And I think that may start to increase as more awareness becomes of the Lyme myocarditis. Yes?
Are you seeing in the CDC that would point you to the progression of Lyme disease?
I do not know the answer to that.
Yeah, one of the forms that we provide in the last slide has a really helpful, it's like a reference manual put together by the CDC. It's available as an app now. It goes through disease by disease, which tests should be used for which disease. And what
I know
they provide.
Some indications on where to look at or Babesiosis.
Right, exactly. You see that used quite a bit more for Ehrlichiosis.
Yeah. Okay.
And, you know, it's just...
maybe liver enzyme counts just to
right.
a general sense of something is going on in this patient. Yeah.
And it may clue you in that it may not be Lyme disease as well. I think in general, like when you have some sort of infectious processing, doctors tend to run CBC just to have that.
General.
Yeah. At strep throat, they ran it, so... Okay, lab testing anaplasmosis and ehrlichiosis. I really like this. Up until 2008, anaplasmosis was known as a subset of ehrlichiosis, although they are now recognized as separate conditions. The recommended laboratory tests are essentially the same. Immunofluorescence assay is considered a confirmatory test, diagnostic test in paired serum samples, but used by less than 40% of providers. We commonly get a single test for Ehrlichia. Honestly speaking, a lot of people don't want to come back for that second blood test. Is one of the issues. So that's one of the drawbacks to that test. Unlike for Lyme disease, PCR has good sensitivity to detect anaplasmosis or ehrlichiosis and is also sufficient for confirmatory diagnosis. In this case, it appears to be underused by about only 20% of respondents. So that's really something, if I learn from this, that we maybe want to push out there to you guys and maybe use PCR instead of the screening test. So. The majority of respondents using CBC to diagnose anaplasmosis or ehrlichiosis can provide general evidence of infection, but it's not sufficient alone for confirmatory diagnosis. And analysis of blood smears can also provide supplemental evidence, particularly in the case of anaplasmosis due to morulae in the cytoplasm. You know, I don't see a lot of that being done. I don't know if it's just not practical or the timing of it as well, you know, because you have to have enough organism to see the morulae. So just because it's negative, it doesn't mean it's probably not or anaplasmosis or ehrlichiosis. So I used to do those. So. Babesiosis, which is caused by a parasite, has a slightly different profile of recommended labs. In the case of a blood smear with parasite identification, is sufficient for confirmatory diagnosis, which is used by over half respondents. PCR may also be used to identify the Babesia parasite for confirmatory diagnosis, and has been used by about 25% of providers who responded to the survey. CBC, again, is commonly used but provides only supplemental evidence. IFA can also provide supportive evidence in the case of a Babesia infection, but does not distinguish between active and prior infections. Again, the one thing with Babesia with the blood smear also, you have to have a really good technician to find it. And number two, the viremia, or the parasitemia, sorry, not viremia, is usually low, so it's not always evident in the blood smear. So that's probably some of the drawbacks. But it's not a bad idea to run it, because if you find it, that's a slam dunk, you know, it's Babesia. They will discern it between falciparum and malaria as well, so always taking a travel history is good. So, because some of the stages look like Plasmodium falciparum. Rocky Mountain Spotted Fever, only 26% of respondents have tested patients for Rocky Mountain Spotted Fever, which can be confirmed by PCR, IFA, or IHAT staining. CBC remains the most common tool, but again, insufficient alone in confirming diagnosis. We don't have a ton of Rocky Mountain Spotted Fever here, thank goodness. The few cases that I've ever really confirmed usually have a travel history associated with them. It's more common in the coastal area of New York State, Long Island, and stuff like that, where you get more of this. Definitely down to the southern United States. Common, even though it's called Rocky Mountain Spotted Fever. But the thing about this is talking about emerging pathogens. They're finding what we call rickettsial diseases. There's new ones coming out, so we don't know if like there'll be some new one coming. So and what's approaching this area, which the deer tick is for the most common tick that infects humans here, but we're seeing a movement of what we call the Lone Star tick up in this area. And these rickettsial diseases are far more associated with that tick. So maybe, we do have the American dog tick, but I will say one thing from my personal experience, I don't know if this is fact, but over years I've seen a decline in the number of those specimens brought in. I don't know if it's for two factors, that people can recognize that versus the deer tick, they don't bother bringing it in. Okay, or we're seeing less of them in the area. Because what happens is if the deer tick population explodes, it may cause a decline in the other tick species. Because the American dog tick is another generalist like the Ixodes scapularis. So if we have one that's more dominant in that niche, it may reduce the American dog tick numbers as well in the area. But again, it may just be everybody's more savvy at knowing This is, commonly people call it a wood tick, but anyway, the American dog tick versus the deer tick. Because because Rocky Mountain Spotted Fever is associated with the American dog tick in this area. Okay. And another thing in this area with the American dog tick is tick paralysis, which we've had 2 cases of in Dutchess County in my tenure here. Thankfully, both the young girls survived, but it's a toxin given off by the tick while it's attached. And usually with young girls, it's because they have tons of hair, they're usually, the tick is here. The one girl almost died in Westchester County Hospital, and thankfully a doctor came in and looked up her hair and found it. And the cure for this disease, the treatment, is to remove the tick. Okay? So it's not an infectious disease process, but it's something, and actually it's something that Dr. Caldwell at the time made reportable by local providers, not nationally reportable, but because of it, made it reportable. And where the vets are supposed to report as well. Happens in dogs also. So, these are asides. And then this is the slide I was talking to Katie about, the laboratory testing for Powassan virus. Limited testing is currently available for Powassan or deer tick virus, and it's provided only through New York State and CDC. The science of testing for Powassan is still evolving, but currently the preferred technique is known as the plaque reduction neutralization to help isolate viral antibodies. That's not the test you would run. Like I said, you could do commercial testing for West Nile if you suspect encephalitis, and if it's positive, they're going to send the specimen up to Wadsworth for confirmation. But if you want to not use the commercial lab, you can go on I was talking to Dr. Robinson earlier, you can either contact us and we can help you, but look on the Wadsworth website for submitting samples for testing for encephalitis. I would recommend and if you think encephalitis, run a panel, because it could be mosquito-borne, it might be tick-borne, it might be something else. And they run a complete panel for it. Okay. Okay. Moving on, prophylaxis case study. A 17-year-old presents to the practice approximately 24 hours after removing an engorged deer tick from her leg. She reports spending time outdoors in local region about 2 days before discovering the tick. She currently does not exhibit any rash or other symptoms of tick-borne disease. Moving on to practices around prophylaxis for tick-borne disease, which include the following case study. And I know it's little check marks, I just see those. If we review the current prophylaxis guidelines for administering a single 200 milligram dose of doxycycline, we find that the case meets each of the following criteria. The tick can be reliably identified as a deer tick. I will tell you that if you have trouble with that, you can bring it to the have the patient bring it to the health department for free, and we identify it, and you'll get a formal report sent to your office. Okay. Tick was estimated to have been attached for at least 36 hours based on the degree of engorgement or certainty of time and exposure. And the thing about us identifying the tick, don't delay your treatment because we're not going to identify it like that. But we have a formula where we can determine the number of hours the tick was attached. Okay. Okay. Prophylaxis can be started within 72 hours, 3 days of the time the tick was removed, because that's the key to this as well, the timing of the treatment. That's why don't delay. If you suspect, it's a single dose of doxycycline. You can send the tick later if you want to do that as well. At least 20% of local tick population is known to be infected with B. burgdorferi, the bacteria that causes Lyme disease. And if you think adult ticks, let's say it was an adult female, 50% of adult ticks are infected with B. burgdorferi, about 20 to 25% of nymphs. So like if it's adult, it's even more likely. And the patient is not pregnant or less than 8 years of age because it is doxycycline we're using.
Okay.
Given the case study, which of the following best reflects the practice's first course of action? Responses to the case study varied significantly by specialty. Almost 70% of adult primary care providers surveyed would prescribe the single dose of prophylaxis doxycycline in follow-up, compared to less than 40% of all the providers. Children's primary care providers were about evenly split between the single-dose prophylaxis and waiting 4 to 6 weeks to test, even though the case study patient was old enough to receive prophylaxis. 30 to 50% of specialists would refer the patient to a primary care provider or infectious disease specialist, although the time window to administer prophylaxis is very narrow. One of the things we're working on is a CHIP, Community Health Improvement Plan, and this is one aspect of the CHIP that we want to sort of get out there. One of the providers, Dr. Sabia, on the CHIP group was really passionate about this and thinks that more providers should be aware of this option for potentially causing disease, having somebody being infected. It is controversial, and yes, sir.
How effective is the Lyme dose?
It's not. This is treatment for Lyme disease, not recommended if you suspect Ehrlichia. It's treatment for Lyme disease, and it was based on one study, and CDC does recommend this as part of the guidance. So, but like I said, what you're bridging on, there is some controversy to the study. A lot of the Lyme advocate groups do not believe in this and believe that, like, if you suspect Lyme disease, you should just give the full course of treatment. And that would be based on your comfort level with this as well. I mean, if you think it's Lyme disease, you can give the full course of treatment. But it's only based on one study, as far as I know.
I was taught to use 10 days of doxycycline twice a day, 100 milligrams twice a day for 10 days.
Just on the basis of a bite?
Just on the basis of a tick bite? Yeah.
And I never had any problems.
Okay.
I never had anybody come back with Lyme disease or Ehrlichiosis or Anaplasmosis.
Yeah, the recommendation would be to follow up with the patient after the single and then do the testing in 4 to 6 weeks to confirm that it's been effective.
Mm-hmm. Well, like I said, I almost think, I always think of medicine as like, we give recommendations, but like there's also the art of medicine, and if you feel comfortable with that, it sounds like you're being effective. You're at least meeting the minimum requirement of the single-dose doxycycline for a tick bite, but you're going beyond that, so. Okay, this is the usual process of handling notifications of tick-borne diseases. This is some subject near and dear to my heart, okay, and I'm finding that, like, before I get into this, what was written here, but like, I gave a presentation on congenital syphilis last month, and the issue came up about having to pick up the phone and call us when someone has syphilis, and many of the providers in the room said, we don't have the time to do that. We depend on the lab to do this. And, it really is a conundrum for us because you guys are enormously busy, and for you to take time out of your day to have somebody call us about something, it's completely understandable. So it's definitely something that I have to, as a health department, we have to look at, one of the ways we're looking to solve maybe this problem is what the RIOs, or Regional Health Information networks, and what they'll do is allow us access to your records so that when we get the lab, we don't have to call you on the phone and, like, ask you to answer all those questions. We can go look, because we have the right to look, as for an investigative purposes, and we'd only sift out the information we need. But they are working towards that in this area, and that would be, it would save you time, it would save us time, and we could actually work quicker at, like, getting these things done. Because, like, for Lyme disease, just so you know, we print out a Dear Doctor letter. One of our support staff people fax it to you. Somebody in your office gets it, gets the chart, circles the things, faxes it back, and then, like, we can whether confirm one of those 11,000, whether it meets the case definition or doesn't. Then if we don't get it back, then we have to send it again or make a call. It's just a lot of, like, it's needless. If we could actually peek in there and get what we want to get out, you wouldn't even know it happened, okay? And, again, you know, I talk about confidentiality. I mean, you know, I've worked with STDs like since starting the job. We've never breached anyone's confidentiality at the health department. It's not what we do. I hold that very sacred to myself. It's like, you know, I would never want to breach someone's confidentiality around any disease issue. You know, but I started in STDs, where it's a very big thing, and it's just ingrained in my head. So, well, once a diagnosis is made, we ask providers about their usual method of handling disease notification. The large majority of survey respondents primarily rely on lab to notify the health department of test results. We appreciate the honesty and do recognize the challenges in active disease reporting. There are a few important reasons for directly to report. When cases of Lyme disease are diagnosed and treated on the basis of EM, rash, without lab testing, this will be missed on our surveillance, and for consultation on testing or treatment. I will say one thing. When I took over the Lyme disease program in 1996, and what I did, because I'm such a go-getter, I decided to put out a flyer to all providers with little targets that, you know, pick up the phone and call in if you see a EM rash. And that, for July, I got 700 reports of EM rashes phoned into me. So, like, it was there. And I have to be honest with you, I think there's probably that many still happening. We just don't hear about them anymore. It's sort of the whole thing about if a tree fell in the forest and you weren't there, with, you know, that kind of thing. So, you know, one of the things I'd like to reinvigorate, I understand the ones with the lab reports of that, but we aren't getting the reports of EMs, and we need to find a way to make it easier for you to do that. Because I understand, like I said, it's a burden. It's more administrative paperwork. You have a lot of things to tidy up in your offices. I'm aware of that. So we will, you know, and it's hard for us because we're under-resourced as well. I used to have somebody go to some of the larger practices and review charts and get the ones with the EMs as well. So we don't have the resources to do that either. So we got to, that's one of the things out of the survey that I wish we could come up with an answer, because then in our county, it looks like the numbers are steady or going down. Part of it is that we don't do surveillance, like, and we're going to go into that a little, oh, that's the other talk, sorry. There is, we do what we call sentinel surveillance in this county. We only get 20% of the labs reported to us. And then there's a formula they apply based on our numbers, actually, over the years. They came up with this formula, and then it comes up with the real number. But Lyme used to be the most reported disease in the county, but it's waned over the years. And now chlamydia is the most reported disease in the county. So that's the most reported.
That's another story.
Yeah, that's another story. That's the most reported disease in the country, actually, chlamydia, gonorrhea, number 2. So, the thing of it is it's sort of what happens in an area like ours, like I told you, we've been dealing with this since the mid to late 80s, is that there's also a reporting fatigue that goes on. It's like I have sort of joked that we've sort of learned to live with it around here. It's like, you know, people know, doctors know, if a person gets bit by tick, they have a rash, we treat, you know, done, call it a day kind of thing. And, like, you know, so we've sort of become, in places where it's new, this is new, they're going to, like, get on the phone and call the health department and report the rash. You know, here it's like, oh, it's here, we know it's here, you know, so we just want to deal with it. So, and that's the hard thing to make it, you know, to create that importance over time to, like, say, pick up the phone and call an EM rash when I want you to pick up the phone and call about somebody with symptomatic syphilis, okay? Yes?
I mean, do you have an electronic version? I mean, we keep copies of that, because mostly what we see in the office is EM, you know, that's what we're going to see and report. And, I mean, if you had an electronic version of that, you know, yeah, end of the day, if you see, you know, 2 cases or 1 case, you just put it in a favorites, open it up, fill it out electronically. That would even be easier than filling it out on, you know, with pen and paper, then, you know, copying it and then faxing it to you.
Do you think, actually, that sounds like intriguing, we'll keep that as an idea from here.
Possibility, yeah. I mean, again, we're still hopeful about the electronic medical record being helpful for all reporting requirements. But
Depends on how much that interchange is going to cost.
Yeah.
sure.
It's upwards of $1,500 a month.
For a long time.
Yeah.
And it's a way off the, but it's definitely a problem that I like your solution to that. It's like, you know, maybe what I might do is like, you know, get a group of you together and come up with like ask your ideas and how, because more we need to hear from you. If you say this will work, I think we can make it happen. Kind of thing.
I think it would be just as fast, if not easier. Again, you bookmark the page, you hit it, it's there. As long as it's a PDF or something like that, you just fill it out instead of on paper, and then you close it. And you have it in your database. We don't have to do those couple of steps to get it faxed to you, because once it's faxed to you, somebody's got to take that and put it into your database.
All right.
So I think it would actually be faster from our standpoint if you had an electronic version of it.
Okay.
In form. I mean, the form's not so bad.
No. No. Yeah, we definitely something. We'll see what.
Limited IT resources.
I'm not going to do it on
No, actually, but you know, honestly.
No.
Because I don't think we have an honest picture. Because one of the things when I used to do those 11,000 reports every year, and that's where they came up with this formula. But I would tell you that half of the confirmed diagnoses were not laboratory-based. They were just EMs reported without labs. That's gone way down. We almost see none of that. It's all laboratory-based. And that's why the numbers have artificially gone down. And it seems like the other areas have more Lyme disease here. Like, I'll give you a good example. Westchester's not even in the ballpark anymore, and they used to lead the state as well. Again, some of the same things that are happening to us happened there already, and that was there first. Now it's moved up to us. So, you know, so yeah, it's definitely something that I would like to, you know, get back, because that is where most, if you see nationally, most confirmed cases are confirmed by EM rash. And we're not seeing a lot. And I know that you guys are seeing them. So, all right. Finally, we asked about patient education, first exploring how often discussion about tick-borne disease prevention occurs during routine checkups. Over half of pediatricians and family medicine specialists report discussing tick-borne diseases most or all the time during routine exams, which is the green portion of the bar. About 30% of primary care providers routinely discuss tick-borne diseases with their patients on a regular basis. Specialists are less likely to discuss tick-borne diseases on a routine basis or at all, but again, we would not expect certain specialists to encounter tick-borne diseases in their practice. But, you know, the one thing about if you're a provider in this county, no matter what your specialty, it should be something you should be aware of, because, you know, you might see something that the patient's not noticing. So. Patient education materials in waiting rooms. Over half of children's primary care providers and 40% of adult primary care providers routinely have pamphlets and brochures in their waiting rooms to educate patients about tick-borne diseases. Very few specialists routinely have patient education materials on tick-borne diseases in their waiting room. You can get the materials for free through New York State Department of Health, so you don't have to, like, buy them or anything like that. And if you want information on how to get that, I think our numbers at the end, and they can guide you to where to get that stuff. But I think it's a good idea to have it out in the office, so like people, it's a way to educate the patient when they're thinking health at that moment. They have the brochure that actually might make a connection to maybe even altering some of their behaviors so they don't get exposed. Interest in tick-borne disease, CME. Last but not least, we are pleased to learn that the majority of respondents would be interested in additional training on tick-borne diseases for CME credit. In March, we distributed an advisory to all practices in Dutchess County with information on free online CME opportunities. We'll provide the link again at the end of the presentation. I wanted to ask you something. We sometimes send out advisories and stuff like that. How many of you guys see them? Okay, so not all of you. Okay, and that I honestly think that that is one thing I've always wanted to think we should look at, is how you guys get those advisories, because I don't think all of you see them. I'm now off topic, but like on the STD front, on the syphilis, we send out advisories about MSM syphilis and HIV in MSM as well, and in adolescents, and a lot of providers said they'd never seen that, or it's like the first time they heard it and that kind of thing. And so and I know you guys are bombarded with a lot. So like you said, it's like we need to talk more with you about what's effective for you that we can, because we can put up blast fax things all day and we think we're doing something, but we're really not. So.
Yeah, we are trying to get better about email now.
Yeah, good. Thank you, Katie.
But it is always a challenge because emails change and knowing who to send it to get to the right channel.
The limitations of the survey. The size sample reflects an estimated 10% of practitioners in Dutchess County, and it may not be representative of all practitioners of an individual specialties. Participants may have a stronger interest in and more experience with tick disease than non-participants. That's why I'm thinking in the beginning maybe the clipboard going around to places that may not be as motivated to be participating would give us a more honest picture. I think other providers might be afraid that they're because there is some controversy associated with Lyme, about being ostracized or singled out. We maintain the anonymity of the respondents in this. So questions were modified in 2014 to improve specificity of responses for different tick-borne diseases. Not all are directly comparable to earlier surveys. The surveys we've done over years, it was a work in progress. I really think we came up with a really good tool this time that if we do it in the next couple of years, we can make great comparisons. And one of the things for us, this is for us to learn how to improve reporting or educating you guys or what you need. Okay, that's all right. Comparison with previous surveys. Concern about tick-borne diseases remain high, similar to earlier surveys in 2005, 2008, and 2010. Slight decrease in testing upon patient request from 82% in 2005 to 55% in 2014. Slight increase in routine testing from 3% to 7% in 2005 to 2014. So at least if the patient comes in and says, I want a Lyme test, you're not doing it on a request. That's active disease reporting to DCODH was the lowest measured to date, 23%, but the question was modified to identify unusual course of action versus any methods of notification ever used.
We were trying to get a better sense of the frequency. In the past, you could check all options, so we didn't really have a sense of which ones you used more than others. Right.
So, like I said, we've gotten a better. We have Katie, who's working on the survey. We've developed a better tool, I think, to make a better assessment of what's happening out there. And CMA training should emphasize tick-borne diseases other than Lyme and be promoted not just among primary care providers, but also specialists that may encounter tick-borne diseases. Greater awareness is needed of doxycycline prophylaxis guidelines as well as best practices for lab testing. Like they said, the PCR is not recommended for Lyme disease due to low sensitivity, and PCR may be used to diagnose Anaplasmosis or Ehrlichiosis and Babesiosis. Both IFA and PCR are going to be underused in those. And it may be part of the lab you use. It may be easier just to check the panels as well. So it may just even come down to that. I know. Okay, and these are the resources and the phone numbers that if you want to write them down, if you can, I can also, get a copy.
Find a way to distribute them by email or something.
Yeah, would you like that? Or, because I'm going to get your the list of who was here, and I can send this slide out to you guys. Yep. So.
I think they're all basically through the CDC. So if you look for the title of that one, you should find it. And again, the hands up, you can update them, and now it's very easy to app, so you can put it on your smartphone.
Yeah, they have a smart app for tick-borne diseases. They also have one for STDs with the STD treatment guidelines as well. So you don't have to have a book in your pocket. You can actually go on your phone. Okay. So are there any questions? Yes?
Not related to ticks in this, but I know chikungunya
yeah.
was, quite rampant in the Caribbean, and I figured Caribbean's awfully close to Florida, and I thought I saw some things that it's now made it into continental United States.
It is in the continental United States.
How fast is that spreading?
Well, I can go into that. I actually have a whole mosquito disease presentation if I could have done that as well. But yes, chikungunya, yes, what it is, it started in Asia, Africa, now it went to the Caribbean. We were
wet tires.
Exactly. What it is currently we don't have the mosquito, we have not had reports of the mosquito that transmits the disease in Dutchess County, but the mosquito does exist in New Jersey on down. It's Aedes albopictus, or the Asian tiger mosquito. Again, like you said, came over on tires, one of the ways it came over, and it can transmit chikungunya, it can transmit dengue fever as well. The thing about chikungunya that makes it more likely that it can be locally acquired, like even in Dutchess County, if somebody has chikungunya and it's viremic, we have enough virus to infect the mosquito. With a lot of other diseases, like West Nile stuff, we don't have enough virus to infect mosquitoes. And mosquitoes take multiple blood meals during their lifetime, because the mosquitoes are nectar feeders. I'm going way off topic here, but anyway, mosquitoes are nectar feeders, but like a female only takes a blood meal to lay eggs, and she'll do that 2 or 3 times over the summer. So, and that's why she seeks out a blood meal. So she may not infect the first time, but she becomes infected. Whether she feeds on, for West Nile, a bird, or chikungunya feeds on a person who's viremic. So,
Times 3 weeks.
Yeah.
When it's transmittable through the eggs then can hatch positive?
I'm not sure about chikungunya. I don't know the answer to that. I know that you get it from the female mosquito, but I don't know if it's transmitted to the, I'd have to look that up. Yes?
No treatment for that.
No, there's no, it's just supportive therapy.
We had that in I was in Vietnam at the time, 40-some odd years ago. We had that there, and we just ruled out malaria, and if they didn't have malaria, they just said, well, they probably have chikungunya
or dengue fever. And that's the key. If you suspect either one of those, that's another thing. Run the encephalitis panel. There is commercial labs that can do a dengue fever testing, but it won't discern between chikungunya and dengue fever. And they would send that to Wadsworth to differentiate.
We also had scrub typhus.
Wow.
That was
Yeah, these are...
That we treated.
Yeah, because I think typhus is bacterial, if I know off the top of my head. But the chikungunya and the dengue is viral, and dengue is very serious if they get it the second time, because then it can become the hemorrhagic version of it. From chikungunya, most of the time, it's just very painful. They feel like their bones are breaking, and I think that's what the name actually means. It's like, so
it's about 3 months.
Yeah, it's very...
3 months of just, you're in pain for 3 months.
Yeah.
Well, that's great.
Yeah.
I don't want it in the Northeast.
Yeah. So, and one of the things, like I said, for mosquito-borne diseases, I'm going to use the term global warming, but as the temperature becomes warmer up this way, we're going to find more of these species mosquitoes back. That malaria, used to be able to get malaria in the Northeast, and we eliminated that, but that could even come back, believe it or not.
Well, I'll get you back on track then. Any, other than the change in the climate and, weather's weird, it's wet and dry. I grew up in Western New York, never saw a tick, hardly ever. You come here, there weren't a lot of them in the mid-'80s, and it's just like they boomed. And now we keep getting more and more tick-borne illnesses. So is this some kind of biological warfare that somebody's starting? Or no, and seriously, why, any other reasons why the ticks are thriving so heartily in our environment now, other than we're in their environment? And
why is it, I've lived here my whole life, and I never remember getting a tick on me as a little boy. But what happened was that the Northeast, the whole Northeast, is reforestation. The farms have been taken away from the area, and people from the cities are moving to the burbs, and they buy houses and create small patches of forest. In those small patches of forest, you have, because to have predators, you need contiguous, and diversity, you need contiguous expanses of forest. But we have 5 houses around a small patch of forest. And deer and the white-footed mouse, their populations have exploded, and the deer have linked into that. The tick is linked into that, and therefore their population has exploded as well. So we've created a sort of a new kind of environment that is favorable to ticks and deer and mice, because as you know, if you're a property owner and you have deer all over, like munching your plants and running into your cars and stuff like that. So they've almost become pets in some ways. They've learned to live with us, and part of, like I said, part of the cycle. But that's Dr. Ostfeld, Dr. Rich Ostfeld, the Carey Institute, has written papers on this, and he's actually proven that people that live around these small forest patches are more likely to get tick-borne disease than people who live in a more contiguous area. Because, like again, biodiversity reduces the amount of disease in the environment.
Just a comment too. I personally have tried to do testing with local labs, and you keep referring to the tick-borne panel, and I've often said to lab people, hey, we need to have a panel, because what happens is you hunt and peck through a whole list of stuff before you can find the test that you want to do. And it's very time-consuming. So it might be a thought to go to the lab and say, hey, is there a way that we can just say, okay, let's go get the tick-borne panel for people who want to rule out whatever is potential here.
Mm-hmm. And if I were to do that, I would want to include the tests that would be better for you to order than the ones that the lab is running, because, they deal with whatever company that's selling whatever tests. So, and that's the other nuance there. So we'd probably still see for Anaplasmosis or Ehrlichiosis a lot of IFA instead of doing PCRs, for example. So,
exactly, and that's what I'm saying. It might be wise to go to the lab and say, hey, this is really what we need here in Dutchess County.
Yeah. Yeah, because, you guys, like I said, I've said it 1,000 times, you guys are really busy, and we just want to make it, we need these things from you. We want to make it as easy as possible to get that from you. And that's what my job is here. So, I appreciate all of the feedback that I'm getting, and we'll take it on and see what we can do. All right? So, okay. Again, thank you for your time.
Thank you.
Thank you very much.
It wasn't. Same to you. Yeah.
Is there any more papers over here? Hi, how are you?
I'm doing fine. So in your EMR, can you customize and go to the spot on the lab? Set them aside.
Is there any way I could check times from vacant classes, or?
Well, that's a really interesting idea for sure.
Or I would work for free so I could learn.
You want to be taught how to identify ticks?
Yes, I would. If there was a way I could do it, I would love it. That's interesting to me.